good evening, good morning. Welcome to this wonderful and a very unique concept of exhibition and conference by CAKE PIE EXPO. We are here to listen to some great talks in this session. Without wasting much time, I would like to introduce a dear friend from Brazil, and we're very fortunate to have him here, Dr. Renato. And his work has been used in every refractive clinic across the world, from one end to the other. There are very few innovators whose work we see every day in our practice, and be very thankful for what they have given us. And like as a refractive surgeon or a cataract surgeon, that not a day goes without looking at the maps and without remembering him and his innovations. And that's what makes us very honored here to have him here to give two talks. And I would ask my friend Dr. Renato to start his talk and explain to us about the whole idea of what Scheimpflug and in the modern day eras and how it's going to be useful. And I'm sure he has two talks, so he can choose which one he wants to present first, but I'm sure it's the Scheimpflug Imaging first. Dr. Renato, all yours, please.
Thank you very much, Dr. Rohit Shetty. It's an honor to participate in this meeting. Thank you for the great introduction. I'm honored and humbly touched by your words. I also highly admire your work, and it's also a very nice opportunity to be in this CAKE PIE exposition. So when we think about, this is a very large topic. I have a complete course on multimodal imaging on 20 hours of talks, and this is kind of a summary of enhanced refractive screening, why and how we do that. We have financial disclosures, but eventually the most important disclosure we have is with our patients and with our duty to do the best work for them. I also have some collaboration with the BRAIN, the Brazilian Artificial Intelligence Networking in Medicine, that completed 10 years last year. And I start with a quote: "As for me, all I know is nothing," from Socrates. I would humbly interpret this wisdom as the more we know, we need to know more. And this is important that we understand on the diagnostics for refractive surgery, that we have to understand what we have in terms of technology in our hands. And this correlation with the art of war from Sun Tzu, which is also a very classic and wisdom from our humanity. We have to understand what we're trying to achieve and how we are trying to do that. We need to optimize planning for refractive surgery. You need to know if the surgery is going to be on the cornea, phakic IOLs, or if you want to remove the lens. If the cornea has any disease or any irregularity, or if you have any therapeutic aspect, or if it's just an elective procedure. Understanding when doing corneal refractive surgery, laser vision correction, if LASIK, SMILE, or PRK, surface ablation will be the best option. And you can customize that. And preventing complications, trying to consider the best procedure for each eye, from each patient, to prevent ectasia, dry eye, interface epithelialization and SMILE, quality of vision symptoms, ocular pain, and other complications. We have multimodal imaging that starts from the clinical history. Biomicroscopy, central corneal thickness, placido topography is still important because it gives you ocular surface imaging like myopography. We have 3D tomography with the Scheimpflug that evolved to the segmental tomography that we can do with the OCT. And thank for the great work that you do in your center with the research work that we have from Abhijit Cynthia Roy and other colleagues. We have the ability to map the curvature of Bowman's layer with the OCT. Of course, we have high frequency ultrasound as well. This can be integrated to whole eye data from the corneal and total wavefront, ocular scattering, and understanding quality of the optics of the eye. We have ocular biometry, axial length, white-white, ACD, all important for many measurements and planning that we do in refractive surgery. And of course, we are going to the domain of biomechanics. Corneal biomechanics is a fundamental tool for measuring IOP. It's important to get to the domain of the cells, not only the endothelial cells, but the stromal and epithelial cells, and even the conjunctival cells will be very important for confocal microscopy. And here I give a lot of credit to my moderator, Dr. Shetty, whose work on molecular biology, proteomics, and genetics is opening a new horizon for us to use multimodal imaging. So those are the hows. Of course, we don't have all the tools yet even available in medicine, and each refractive surgeon should understand their technologies they have in our hands and optimize their use to best plan for surgery. We have the multimodal imaging, and this is two reviews that we had, one of them in the Indian Journal of Ophthalmology that was very nicely and very professionally edited by Dr. Rohit Shetty last year. I highly invite everybody to look at this publication, which is a great companion for refractive surgery. When you think about enhanced diagnosis goes beyond but not over. That's the classic wisdom that we got from this editorial from 2013 that I was honored to co-author with Brad Randaman, who is our great editor-in-chief of the JRS. But we have to think that screening for refractive surgery candidates is different than managing patients with corneal ectasia. We broke paradigms. We create some paradoxes in this new subspecialty, truly new subspecialty we have in ophthalmology. And we have to be conscious that ectasia susceptibility is not the same as diagnosing ectasia. Staging the disease for clinical management is definitely different, and we have a therapeutic procedure than an elective refractive procedure. And of course, follow-up. And for understanding this, we have many machines. And one of the machines that I have at my clinic that I really think gives me tremendous of information for making those decisions is the Pentacam family. And I was really fortunate to start with the first Pentacam in 2004. And now we have the Pentacam AXL Wave that came last year into my clinical practice. We have the understanding that the diagnostics has to be cautious. And in this multimodal imaging that goes now beyond corneal and anterior segment tomography with the Scheimpflug, we have axial length with the PCI and a Hartmann check sensor for ocular wavefront. We have data to screen for many situations like angle closure glaucoma and of course keratoconus. We started working with moctobelin for the elevation being integrated with my concepts of enhanced corneal thickness for the comprehensive visualization of how the cornea gets thick from the center towards the periphery. And this is helping you to look at the diagnosis. Michael Bellin, a few years ago, he also had a great contribution on the progression display with the ABCD. A is the radius of curvature at the thinnest point in the front surface. This is in the back surface, the radius of curvature in millimeters at the thinnest point. This is the thinnest point, and this is vision correction. And we have the repeatability being nicely presented here. If you have the bars beyond the red one, this is statistically significant. When you think about screening for refractive surgery candidates for ectasia risk, we have to come with the literature. And ectasia is more rare now, but still happens. In this very nice series with 30,000 LASIK procedures by Dr. Bohak, she had 10 cases, and the 10 cases were really hard to be found on the screening susceptibility or screening risk on the classic domain. So the quest to go beyond is unquestionable. And it comes from 1998 when the first LASIK ectasia cases were reported by Theo Seiler. Professor Seiler first described 3 cases of ectasia after LASIK for high myopia. So the impact from the procedure here caused ectasia. And here, a few months later, he published the form-fruit keratoconus case as the cause for the iatrogenic ectasia. And form-fruit here was defined as the inferior stiffening based on placido-disc topography. Considering this, we have 20 years plus of a conundrum. I published that exactly 20 years later. And it was an editorial for Dr. Bohak's paper on the incidence of ectasia after LASIK. And if you think about pathophysiology of ectasia, and I was just talking to some medical students this week in a very nice session, I told them that this concept can be evolved to any disease in medicine. It's related to the properties, to the innate properties of the patient and the impact from the environment. In terms of LASIK ectasia or vision correction ectasia, we have the corneal properties in terms of biomechanics and the impact from the procedure, along with the impact from the environment, which is eye rubbing. So a major concept that everyone should understand is that any cornea may undergo biomechanical decompensation and ectatic progression, and this is related to the environment. This classic wisdom that eye rubbing is bad for you, this should be promoted for every human being in this planet. We should teach our children not to rub the eyes. This is a very general and very easy message, but I believe that the very experienced corneal surgeon may also take something. Rubbing the eye or scratching the eye aggravates keratoconus, but may even cause ectasia. Those are not exactly the same thing. So when you think about enhanced ectasia risk prior to refractive surgery, we have to think in the multidimensional ways. And Brad Randleman came with a very nice concept for integrating data from topography and also from other factors like age. Age is a surrogate of corneal properties, corneal biomechanical properties. We know that aging is related to stiffness of the tissue. And residual stromal bed, the central thickness before surgery and the level of correction will also integrate the risk factor scale. The major point that I would believe we should evolve to is the understanding of what is formed through keratoconus. We have 30% of the normal cases, so-called formed through keratoconus before surgery. In those cases had long follow-up. Of course, you can debate that eventually ectasia can occur at any time after LASIK. I just saw a patient 13 years after LASIK with a stable result, at least after 10 years, she was fine. And she started having ectasia probably before 12 or 13 years. But we have also cases that were really normal at the tomography, even topography and tomography. And this is, when you think about ectasia, 30% of the pre-op are normal and 1% of the pre-op of stable cases are irregular. So we need to enhance sensitivity and specificity. And the first point is to understand what is formed through keratoconus. There is no consensus on what is formed through keratoconus. Steve Kleiss would say that the fellow eye of this asymmetric patient would be the formed through keratoconus, this fellow eye with a normal topography. And sometimes we see the unilateral keratoconus term, which is, I think, is misleading term. But Yaro Rabinovitz, who had great contributions for the topography interpretation in the late 80s, we have the abnormal topography with a patient with a 20/20 distance correct and normal slit lamp as the formed through definition. There is no consensus on the literature. Very nice review from Luis Izquierdo and Maria Enriquez described that formed through keratoconus and subclinical keratoconus are found in the literature with different criteria for the definition. And there is no consensus. We can say there is no consensus because we tried to have a consensus in the Latin America in 2014, and next year we did it at the AAO in 2015, and there is no consensus. And my humble contribution is that formed through keratoconus should be defined as a patient with high susceptibility for ectasia progression. And we came with this paper from the AAO 2008 in a meeting that I debated also about elevation versus curvature. And in this meeting, Doug Koch, Dr. Koch from Baylor Clinic in Houston, Texas, he presented this case. And he presented this case as an abnormal curvature. Because of the abnormal curvature, this patient developed ectasia. Despite of subalbum keratomiliosis, residual stromal bad, PTA low, everything will be normal, but people would say, now that I know that this is ectasia, this is abnormal. So we came with a study on the subjective classification. This was patient number 6. This topographies were sent to many colleagues, all experts in the field. After the first classification, a few months later, we sent the same case with a different scale, and they were asked to classify based on the Randleman criteria: 0 as a normal bow tie, asymmetric bow tie, 1, no 2, 3 inferior stiffening with steel radial axis, and 4 was the form fruits keratoconus, or the irregular classification. This was from 0 to 3 with the first scale, this case, but a huge variability. And in the second scale from 0 to 4, but in both classifications, the experts had a mode of 0. Interestingly, this case was available on the Pentacam with the pre-op data, and we were able to use the U12 files to classify the patient as susceptible based on the D score that was very high. And this is a threshold that I would say the D higher than 1.2, 1.3 will be suspicious. It will turn yellow after 1.6. Artmax lower than 400 defines ectasia susceptibility. And we started collecting those cases, and this is the 105 data. The IS value, which is the asymmetry, the classic Rabinovitz criteria, you have a high specificity, because surgeons look at this and they tend not to do surgery in patients like with asymmetry. But there are cases that are stable even with higher AS-ABS value. This is the absolute symmetry between superior and inferior curvature axial. But it's not specific, it's not sensitive at all. The bad D, which was not analyzed in the pre-op of this because it was not available and those cases were done from multi-center centers, places, we have a sensitivity of 59%. But we have to improve. And when we improve that, we use objective parameters, and we start defining non-disease and disease differently. We start defining disease as the very asymmetric ectasia cases, the normal topography eye, along with the clinical keratoconus. And Bernardo Lopez also had 60 of the 105 cases to be analyzed. And this was used to train AI with cross validations for improving the algorithm for tomography. And we have the Pentacam Random Forest Index, which is looking at the same data as the PET-D, but in a more sophisticated way. And we have a sensitivity jumping from 59 to 74.3%, and specificity also increasing a little bit. But we still have cases here. And the cases here, we have to go beyond, not over. And I do believe biomechanics is on the way to find the real clue for biomechanical susceptibility according to the concept of B.J. Dubs and Cynthia Roberts. And we integrated tomography and biomechanics. We will hear about the integration with the ARV with Riccardo Vinciguerra. And I come with one example here that kind of summarizes everything. This patient comes as a refractive candidate. He has 20/20 -1 distance correct vision. He is a presbyopic patient with an NAD of 2.75, and the fellow eye is very normal. The first thing is that the fellow eye, the left eye, has a little bit of abnormality on tomography, but when we enhance that, we don't see much of abnormality on the bad D. And some people would call, Renato, you see, this is a case that the D is not abnormal, so we fail to detect the susceptibility. And when we integrate the data with tomography and biomechanics, we really have no question about the abnormality that this patient has. I would say this patient has a cornea that is susceptible based on the tomographic and biomechanical integration. And the fellow eye has a TBI of 1. And interestingly, this patient has this lens dysfunction. And based on the understanding of Scheimpflug imaging, we can tell the patient eventually not to do any surgery because we don't have this patient is still 20/20 with a relatively clear lens, and we should follow up. So lens staging on this lens dysfunction is very important. And sometimes you have surgery, you have the exams to tell patients not to do surgery for multiple reasons. Another candidate that came recently, she 72 years old, you see from the Hartmann check from the wave, you have some abnormality that can be correlated with the retroillumination picture. And you can show that to the patient eventually for patient education and tell the patient to do surgery, not only because of the lens, which is a little cloudy and she's still relatively happy with her this correct vision, but because also she had a posterior corneal higher peak on the densitometry. And this is related to the second peak on the decimates level, and this is related to Goutte. So I told her, let's do surgery now because your lens is a little, still not so hard, and you have a kind of a weak endothelium based on this data. And interestingly, she has also some abnormality on the front surface, which integrated, I would say that she has both kind of mild keratoconus along with Goutte. We have the understanding of endothelium for Fuchs dystrophy as part of our algorithms for understanding the refractive surgery candidates. And we published a few years ago the importance of screening for cataract surgery for multifocal lenses and the association of keratoconus and Goutte. And of course, we need to have enhanced data to detect that, as very nicely pointed by Sujika Ko on the JCRS a few months ago. Interestingly, the diagnosis of refractive surgery is objective. We need to have customized planning and evaluation of results properly for even further improving the benefits of the technology for planning the next cases with more experience. Characterization of ectasia susceptibility is what we aim for, and lens dysfunction is something that is coming closer to have some treatments for accommodation, restoration that we always have the dream for. Even myself, I am a candidate for that. But refractive surgery imaging is a true revolution in evolution. And I do believe that we'll learn more and more with molecular biology and genetics. And I'm very happy to collaborate in this session to learn more with you and to share my experience on multimodal imaging. So thank you very much for your kind attention and look forward to more discussion and more interactions soon. Thank you.
Thank you, Dr. Renato. Wonderful talk as usual. We'll have some time for discussion, but I have one question for you. In today's context, in 2021, what would be the right word instead of formfus keratoconus? Because this is something which everybody uses all the time, but what do you think would be the right word?
Susceptibility, susceptible. What we're trying to come with the TBI, with the tomography and integrated biomechanics, is an index for susceptibility, is an epitome for defining how this cornea can be weakened eventually by laser vision correction safely. Of course, ectasia risk is always going to exist, as risk is part of the natural presence in the earth. Risk is not zero ever, but ectasia susceptibility is the level of risk that you are willing to take, and this is the best name. But I'm willing to learn and to really evolve, because frust is frustration. Frust is incomplete, frust is crude, frust is confused. Actually, frust defines perfectly what it is, because it doesn't define anything.
Absolutely. Thank you. I'm sure we'll have time for discussion at the end of your second talk at the end. It's my great pleasure to invite my other friend, Dr. Vinciguerra, Riccardo Vinciguerra, to give his talk. I think his talk is pre-recorded. So can somebody play his talk, please?
It is a real pleasure to be here in the CAKE PIE EXPO. I'm going to speak about corneal biomechanics in 2021. What is the ideal pre-op assessment of a patient before refractive surgery? That is reliable, that is easy and fast, that is validated, and it has high sensitivity, which means that you detect all risky cases and you don't treat them, and you avoid to exclude too many, so you have high specificity. What did we do for this? First of all, we introduced an index that is called Corvis Biomechanical Index. that was aimed to detect keratoconus based on biomechanics. It was published in Journal of Refractive Surgery in 2016, and it was awarded with the Troutman Prize in 2017. How does it work? It has a cutoff of 0.5. Healthy patient will be between 0 and 0.2. Patients that are at moderate risk of ectasia will be between 0.2 and 0.5, but most of them will be 0.0 to 0.2. Abnormal case will be more than 0.5. How did we create it? The idea was to separate between normal patient and keratoconus. And we did a study in which we included more than 600 patients, and we got a validation dataset. In the validation dataset, a sensitivity of 100 and a specificity of 98.4. But you might say, how does it work in clinical practice? So I do the curves, and how does it work then? Let's see an abnormal patient. You get the CBI in two screens, the Vinciguerra screening report that you need only biomechanics to get this, and the CBI is in the bottom right. You can see that this abnormal patient of this keratoconus has a CBI of 1. But what about in difficult cases? So you might say, I don't need biomechanics to detect keratoconus. Let me show you this case. This is a patient with very normal cornea. Slightly thin, 505, but normal anterior and posterior elevation and a Kmax of 43.2. If you look at the Bailey-Ambrósio, which is based on tomography instead, the final Bailey-Ambrósio is 1.18, which is absolutely normal, and less than 1.6, which is the cutoff. But look at the CBI. The CBI is 0.99, which is absolutely abnormal. What about if you look at the left eye? The left eye instead is keratoconus. And you might say, oh, how did I miss it? And the CBI is abnormal in both. What we proved is that many patients with abnormal biomechanics, they have normal tomography. So this patient that looks normal in one eye, they are abnormal in both eyes with keratoconus. So then you might say, well, if I use also biomechanics, maybe I will lose a lot of candidates for refractive surgery. It's not true. Let me show you this case, for example. This patient is a patient with very thick cornea and also normal tomography. But the final D is 2.45, so it's abnormal. You might say, I'm not treating the patient. Let's see the other eye. Also, this one, very normal. It's a bit steep, we must say that, but it's very thick. And again, the Bailey-Ambrósio is abnormal. But look at the biomechanics. Normal CBI in one eye, normal CBI in the other eye. And we have safely treated this patient with refractive surgery, and the patient is stable since years. Let me show you another interesting case. This is a patient that was referred to me some months ago for a monolateral keratoconus with decreased vision and quick decreased vision. She was also considered for cross-linking. This is the tomography and the topography. You can see that the right eye has an inferior steepening with a fairly looking left eye. We did biomechanics, and the biomechanics was normal in both eyes, was 0.3, which is not 0, but is normal. So let's look at the epithelial maps. The epithelial maps were very thick. So the cornea was crystal clear. So I spoke again with the patient and I say, did you have anything that you didn't tell me before? And she said, well, it must be said that I had an incident with boiling oil and one drop of oil went in one of the two eyes. So this was a hyperplastic epithelium. It was not an abnormal eye, it was not a keratoconus. So we just suggested an alcohol-assisted epithelial removal, which will be done in the following weeks. Let me tell you about something new, the CBI-LVC. The CBI-LVC is a new index that we developed to separate between patients that are stable after refractive surgery and patients that has ectasia. We know that laser vision correction is widely accepted to correct refractive errors, but we also know that even if it has an axis safety profile, small amount of cases can develop ectasia after PRK, LASIK, and also SMILE. The early detection is very important because you can treat them with cross-linking and avoid progression. Unfortunately, up to date for early cases, the only thing you can do is to do differential tomographies, and you show that this patient is getting worse, as Renato showed in the SMILE case. The incidence of ectasia is very low. It is between 0.04 and 0.2%, but it's still, remember that these are healthy patients, so it's a disaster for them. And ectatic changes can happen years after surgery. So it is important to know that, as we have seen, SMILE can cause ectasia, and also LASIK extra does not prevent ectasia. So how can biomechanics help? We know that in keratoconus, the first hit is probably a change in corneal biomechanics. So maybe the use of biomechanics, even in ectasia after refractive surgery, can help. But there are many challenges, because we know that patients after refractive surgery, they look similar to keratoconus for biomechanics. So you need to be able to separate between keratoconus and patient after refractive surgery. Once you're able to do that, you also need to separate between stable patient and patient that has ectasia. So we asked for help. Around the world, all of these friends, we were able to include many more patients, and I'm going to show you what we achieved. This is published in Journal of Cataract Refractive Surgery, so if you're interested, it's still online ahead of print, but it will be in the next issues of Journal of Cataract Refractive Surgery. So we aimed to create a new index named CBI-LVC to separate between stable patient and ectasia after refractive surgery, and to validate it in a very big data set. And we also wanted to create a semi-automatic approach, which I will show you in a second. So the aim one was to create the CBI-LVC. So 736 patients, in particular, patients around the world, so different ethnicities, stable patient after refractive surgery, and ectasia. It is more important to tell you that these patients were a lot, and particularly we had 51 ectasias after refractive surgery. As you have seen, it is extremely rare to have a patient with ectasia after refractive surgery, and these are all untreated patients, so you can imagine how difficult it was to get these patients. Inclusion and exclusion criteria. We included only patients with at least 2 years of stability after refractive surgery, and all ectasia were confirmed by another corneal expert. Statistical analysis, we used logistic regression, and we have used 80% of the database to train the algorithm and 20% to validate. I'm going to show you the validation only, because this is the only important thing you want to see to exclude overfitting. So we got a sensitivity of 93 and a specificity of 98. So we are able to separate between a patient that had a refractive surgery and ectasia just with a puff of air. So just with the Corbis. So how does it work in clinical practice? The problem in clinical practice is that either you tell to the machine that this patient had refractive surgery, or it might be useful to have a semi-automatic approach. So the semi-automatic approach works like this. You need to be able to separate between keratoconus and normal patient, which we can do with the CBI, but then you need to be able to separate between patients that have refractive surgery from keratoconus, because they are similar for Bailey-Ambrosio, CBI, and TBI. So we needed more patients. So we included 4,280 patients, and these were healthy patients, keratoconus, stable patient after refractive surgery, and the ectasia. So basically what you want to do is, if a patient goes to your clinic and you want to know if it is abnormal, first of all, you want to know if it is normal or everything else. So keratoconus and laser visual correction. And you can do this with CBI, because you remember that the CBI is also abnormal after refractive surgery. So this is a very good step. Second step is a new version is a new index that is able to tell you a warning. Maybe this patient had refractive surgery. And once you have done this, you can apply the CBI-LVC. But it's very difficult to see this in a flowchart. Let's see it in clinical practice. But before, I want to make a small discussion. So to our knowledge, this was the first time that an index based on biomechanics was able to produce such an efficient separation between stable patient and patient after refractive surgery with ectasia. To our knowledge, this is the biggest database in history. And the presence of an external validation dataset confirms this and excludes overfitting. and the fully automatic approach is only based on biomechanics. So in clinical practice, so this is a patient after refractive surgery, sorry, a patient with keratoconus. You can see that the CBI is abnormal, the TBI is abnormal, and the bed D is abnormal, as we are used, and this is the TBI report. Also in the Vinciguerra screening report, the CBI is abnormal, more than 0.5. This is what we are used to. What about a patient after refractive surgery? Let's see that you open the TBI display. You get a warning and you get, we think that this patient had refractive surgery. If you click either post-PRK, post-LASIK, or post-SMILE, or just post-LVC, you get that the CBI turns in CBI-LVC, which the cutoff is always the same, 0.5. And you can see that the bed D and the TBI, since are not applicable after refractive surgery, get grayed out. You get the same warning in the Vinciguerra screening report with the CBI that gets the CBI-LVC. And also here is normal, obviously. Let's see an ectasia. You get the same warning. You maybe click post-LASIK, and you get that the CBI turns in CBI-LVC, which is abnormal. Vinciguerra screening report, same thing, because remember, with the CBI-LVC, you just need biomechanics. You do not need tomography. And here you get the CBI-LVC. Last case, the one that Renato showed you. You remember? The one that developed ectasia in the right eye? Does the CBI-LVC detect ectasia after SMILE as well? And the answer is yes. Let me show you the CBI-LVC. This is in the last scan before the implantation of the ring. You can see that the CBI-LVC was abnormal. But then you might say, well, you know, I want to know if the other eye that did not develop ectasia, the CBI-LVC is different. And the answer is yes. You can see that the left eye that did not develop ectasia was normal. So it was able to tell you, take a look in the right eye, because the right eye looks abnormal compared to the left eye. So to summarize, how can you use the CBI-LVC in clinical practice? When you have a patient that you think that has ectasia, but also if a patient has a change in refraction after refractive surgery and you think, is it an ectasia or is it a regression? The CBI-LVC can help you to tell you it is a regression, it is not an ectasia. So this is very important. So this is a new tool that it's already available in the last software of the Corvis that will help us to diagnose earlier and treat earlier this very terrible disease. Thank you very much. I send my regards to everybody, and particularly to my two colleagues, Renato and Dr. Shetty.
Wonderful, wonderful, Riccardo. I think not here, otherwise, are you here? So he's not here. So otherwise, we could have had some great questions to him. The third speaker is going to be myself. I'm going to speak about some unusual cases which will help to understand the biomechanics. Can you share my presentation, please? Hello, friends. I would like to thank Matt and his young team for creating such a wonderful format of meeting. I'm Dr. Rohit. I come from Bangalore. I'm going to share something about few cases on the biomechanics. Let me share my screen. This is my presentation on biomechanics to the rescue in complex cases. These are my financial interests. My friends have already discussed about the biomechanics and its variations in how it helps to understand, how it helps to how it helps in your clinic. The center will always be in the bad D, and these are all our dilemmas we can come across. When your bad D is on your suspicion, but your biomechanics is normal, the CBI and the TBI, and sometimes you can have this being abnormal. These are all the situations which kind of confuses a new biomechanical tool user in modern day refractive surgery. So the question which comes to us is, what's the true picture? Will I practice? My practice reduce because of this? Because will I send home patients who are perfectly normal, but the biomechanical parameters were not normal? Let us help to decode these indices and how it helps in the patient care. The modern day refractive practice is like this, the 6 blind men and an elephant. Each one of us are picking one part of it and trying to make a story out of it. So my idea here with the next 4 or 5 cases is try to help us decode every aspect of this confusion which happens when we are a new first-time users to the biomechanics. So now we have the corneal tomographer, you have the biomechanics, and let's look at this patient. This is a 26-year-old female come for the refractive surgery option. And you can see that there's some small changes out here, a small change of elevation. You can see that there's a difference of 1.2. The band D is on a lower side. The TPI is perfect, and the CBI is also well within the normal limits. And of course, there is a small amount of elevation on the back side. So what's the biggest masquerade is in today's practice is the epithelium. And this is what we published before the era of the modern day hybrid tomographers today about how we could virtually dissect it out and plan what is really hidden under the epithelium. So when we look at an epithelial mapping of this, the same area is actually having some changes out here. And this is what is picked up by your indices. But the most important thing, the band D and other things were normal. So if this CBI and TBI were normal, this is probably the best indicator of power of using the corneal topography plus the biomechanics is in this particular case. The reason is if we had only the biomechanical indices, the topography indices, then probably we would have considered this as an abnormal one. But when you look at this, and there is a new index called stress strain index, which looks at the strength of your cornea, and this is independent of your intraocular pressure. And anything towards 1 is always normal. Anything less than 1 is considered weaker cornea. So what you see in this picture is a clear example that even though the topography indices were slightly on a riskier side, but your biomechanics was normal, which made me to clearly go and operate LASIK for this patient because I felt that this was completely healthy and I don't have to worry because it was more of an epithelial issue. So in these patients, I want to digress a little bit. A healthy epithelium, a healthy meibomian glands, an unhealthy epithelium has a very poor meibomian glands, and you can see that there are microneuromas, dendritic cells, all types of things on your confocal microscopy. And what really happens is if you operate on them, the healing is going to be completely different. And this is a healing of a same patient with a poor meibomian gland. This is how the epithelium is completely irregular, and see that the nerves have become healthy. And here, these are all your dendritic cells. And the nerves are very fragile and hardly seen, which means that there is a tremendous amount of stress on the system. So what do we do is when they heal properly, your quality of vision is also good. When they don't heal properly, the quality of vision is not bad. So these patients would need a lot of medical line of treatment or also some amount of vision pulsation treatment, the heat-based treatment, which probably is not part of my talk today. Just what I'm trying to say is that these patients who have an irregular epithelial or having an irregular indices needs to be taken care differently, both preoperatively and postoperatively. And in this patient, because I had the power of the biomechanics here, I was able to do this procedure, and the patient is quite comfortable, and I don't expect anything from this patient at this point of time. This is just an example of how just one indices may not help you in your future of refractive surgery. Coming to the second case, what we see here is, we have discussed this the cornea and tomographies together. And here we have one eye where you have the bad D is a little on the suspicious side. You have a posterior elevation here. The TBI is a little on the yellow, and this is also coming towards suspicious range. The SSI is not on the 1, it's less than 1. And this again, this is in this case is completely normal. So what we wanted to do is, when we have this kind of a picture, this is always a confusing one, when it is not completely normal, nor it's completely abnormal. It's in between. So this is in between, and this is in between. So this is where we are always confused. And this is, again, one of the most confusing times for a refractive surgeon. So what we did was, our team has been extensively working on a new way of looking at the collagen. We call it imaging the collagen, but it's not direct imaging the collagen. It's using the polarization properties of a collagen fibers. So it is not possible because of the wavelength of light and the way the collagens are reflecting light. It's impossible to do it at this point of time in an in vivo method. But we use a different property of polarizers and how the polarizing light, how the collagen polarizes light, and use something like the birefringence properties. And when you see that this is how a collagen looks like, the central one, the darker blues are normal, and you have these peripheral fibers here, which resembles these things, and this is how it looks. So this is how we look at the collagen, and this usually we try to correlate with all the indices out here. Let's go back to our same patient here, and this is your normal eye for the comparison. You have a bad nevus thing, but these things were normal, and these things were normal, but still your indices were. So what we did was we looked at this, and you can see that the whole of the collagen polarization was well in the normal. These are your peripheral fibers out here, which is, is the collagen fibers are like this, and these are your peripheral fibers, and this is what it represents. That means that, again, the biomechanics was giving us the right picture, because here, because this was, I was worried about this part, I was worried about this part, and I was worried whether there could be any reasons to be worried on this. This is not showing, and this is consistent in a lot of our cases. Now we combine all of them, which helps us to clearly understand what is happening. The case number 3 is a patient where, this is bad D is a little on the suspicious, and one eye is completely abnormal, and here it's normal. Now, what do we do with this case? And you can see that it's not a great topography. You can see that there is some amount of scaving out here, and there is some amount of irregularity up here. We have to really be clear what do we do with this, and this is what the PSOCT of these patients do. This is normal, and this also is kind of, we can see that here, there are still some collagen fibrils are missing, and here some fibrils are missing. So the center part looks normal. Here we are still on a doubtful side. But what is interesting here is there is a different intraocular pressures of both the eyes, which we're trying to figure out why. Because if you have an intraocular pressure of 18, probably your indices may look normal, and here the pressures were 7.5, and that's why it's looking thinner. I mean, the same, nearly close to same amount of pachymetry. So what we are trying to say is that even though the corneas of both eyes are completely different, always look at the intraocular pressures. Sometimes there is a change of around 10 millimeters of mercury, and this could be an early normal tension glaucoma. We don't know. We were trying to find out to go back to this patient's fields and OCT to really see what's happening. But intraocular pressure difference can be a huge impact in the way the pressures are monitored, the way the biomechanics is monitored. The case number 4 is a case where, again, the bad D is normal, also on suspicious, and you can see the CBI is on a suspicious, and TBI is showing normal. And here is suspicious, this is suspicious, here it's on a suspicious range. And we don't see anything except for a few changes out here, nothing grossly abnormal of this topography. So in this PSOCT, you can see that this PSOCT is abnormal. That means the polarization state of the collagen is not good. And you can see that this correlates very well with this and this. So it's very, very important here that it is picking up something. And, just compare the darker blue colors to this blue here. These are all lighter blue here, which means that the polarization is not good. And you can see only one area is here, and here is completely abnormal. So again, the biomechanics is telling you the real picture. And it would have been very difficult sometimes to look at what is happening. It's just that the way the collagen is behaving to the particular stress is picked up very early by these parameters, much before your topography could show anything. But the question always comes is, what is a real truth? We have looked at biomechanics, we have looked at topography or PSOCT, what is the real truth? And so that the real picture really happens at the cellular level. So what we did was, any of these patients where we have the biomechanics and we had the PSOCT and we had the topography, whenever we do an PRK, we used to started taking the epithelium, and we have our own lab which looks at analyzing all the gene expression of different collagen and different matters. And this is what we call the molecular study. And we call this as a PMC study, which looks at all of them, because this is where, remember what I said in the beginning about the elephant, this is an elephant. You have to pick up every single clue from all this and try to understand what's happening. And look at this patient. You have this, you have the biomechanics and CBI, TBI being, in this case, a little on the lower side. Your PSOCT is showing that it is not good. And your molecular pathways also shows that the lysyl oxidase, which kind of holds the collagen. These are all, when your collagens are like this, these are all the enzymes which holds the collagen. And this is what lysyl oxidase is. And you can say that this is on the lower side. And this is your collagen. And this is your collagen, all the collagen fibrils, which shows that this is also on the lower side. This is normal. And this is the normal one. This is your patient one. And you can see that both of them are on a really a lower side, which means that your biomechanics here was telling the truth. And that is what is the most important thing when you combine everything out here. So even though it's confusing, more and more as you start digging deeper, you know that it has got a real power to give you the truth and make you understand. The fifth case is a patient, 23-year-old female. You can see that. You can see these two parameters are normal. Only your BAD-D is picking up as abnormal. And, the epithelium is also normal. Everything is perfectly healthy. But when you look at the PSOCT here, again, this PSOCT is not showing great. Once in a while, you get this kind of a picture where your biomechanics is completely normal, but still your collagen may be lower. At this point of time, I don't have a proper explanation to it, because the properties of biomechanics is different from having what you can image on your PSOCT, because you may have a very little collagen, but it may behave it may keep the cornea very strong, or it may keep it very from deformation. So that's one of the only thing I can think about it now. But these are not very, very common. Very rarely I get this. But these are the patients you can consider a PRK or one of the other procedures where you don't want to do a LASIK flaps on this. What's the future is we worked on this predicted prediction model where we look at different types of prediction. And EcuSim is a completely mathematical driven software, which we are working with the team here. And you can use finite element modeling. This is how it looks. You can enter a lot of data out here from your Pentacam and Corvus. And what it gives you is a simulation. That means it predicts the type of changes which can happen. And it can tell you for this particular patient, what is the predicted weakness. And this was given in Newton's per meters, that is nothing but the spring. You can, if you put the springs and if you press the spring action, it comes in the newtons per meter, and you can tell you what is how much of weakness each of these procedures do. Basically, it can tell you about LASIK, SMILE, and PRK, and it will tell you which one. If it's on this side of these, if it, any black band on the red and on your green side means that it is healthier. If it's on this side, it means that you're making the cornea a little on the weaker side. So this is something which you have to be very careful, and this will help you to understand and predict different types of corneal stiffness which you're going to create post-surgery. So, and how do we apply this? From all that what we have done, when everything is good, choose a type of surgeon's preference based on what you want to do, whether it's SMILE, PRK, LASIK. When your biomechanics is normal, but you are structurally, you still see a change, then you consider only PRK or SMILE extra. When your biomechanics is abnormal, then you can look at one of the options would be phakic or a SMILE extra or a PRK extra. Or when all three of them are abnormal, then you probably look at a phakic lens. So some small nomogram which we have designed so that it helps the clinician to use this. And we are working on all these procedures and seeing how does it really change the strength and also the collagen polarization of these procedures, like an extra procedure, both PRK and extra with or without, PRK and SMILE with and without cross-linking, which we call it an extra procedure. These are my team of all the scientists with whom I work, and fortunate enough to share and present their work on with you all. I'm thanking all of them here, and thank you. Thanks again for this opportunity.
Wow.
Thank you, and we will have the discussion at the end of next talk. Dr. Renato, are you ready? Can you have your next talk?
Yes. Very, very nice talk, as usual. We learned a lot, many interesting cases, many interesting scenarios on how the technology can make a true difference for us. So in this integrated Scheimpflug imaging talk, I will just go through what we have done. And I've been collaborating with Oculus since 2005 as a consultant, and it's been a true pleasure. I always start with a kind of wisdom, and the enhanced screening for susceptibility, as you asked, what is form fruus keratoconus, and I think it's a susceptibility, is to make things as simple as possible, but not simpler. And how we try to do that? We first did it with the Ambrósio DE, which is still a very, very nice tool that gives you a summary of the deviation from normality, considering normal and keratoconus. But tomography is an enhanced from topography, but definitely we have to go beyond, not over. Like we have to go beyond topography up to tomography with a thickness profile and elevation in the back surface. But the ARV display is a combination of tomography and biomechanics, and we do that with artificial intelligence. We have the random forest with Live One Out, and we published that in 2017 in the JRS. And here we can see the studies. We transform the bad D into the DI, so it goes from 0 to 1, so we can compare with the CBI and the TBI. And you see some complementary data. But a very important message that I want to be clear is that the TBI is not simply a TBI is a equal of CBI plus bad D. Is not. Bad D and CBI are linear regression analysis, and the TBI gives you a random forest which is a much more complex and sophisticated. It's even sometimes challenging for us to understand what's going inside of the algorithm for the random forest, for the many trees, for making this final decision so that you can come from 0 to 1. But we had one eye randomly selected from 480 normal patients, 204 keratoconus, and we had 94 cases of very asymmetric ectasia, having the 72 unoperated ectatic eyes as part of the study as well. So we have very nice separations for all the groups, not for the keratoconus versus the VAEE, which is the ectatic eye from the very asymmetric ectasia cases. And here we use both eyes when the patient was not operated in the ectatic eye, because those they were defined as very asymmetric. Here we just use for the normals and the clinical keratoconus, both just one eye randomly selected. And we have some separation curves that can pretty much see the benefit of the enhanced approach from tomography to biomechanics and biomechanics integrated with tomography. So we have also a very nice work from Jens Buren from Germany, that he has the separation curves. So it gives you, it's easier to see the separation that you have from the TBI, from even when you have clinical ectasia cases where the ROC curves are pretty high here. So as I told you, is an epitome of the ectasia susceptibility. I used to say that those cases could be unilateral ectasia or form fruus keratoconus. It's not just that. This is basically like a continuum. This wisdom is coming from the glaucoma domain. Dr. Weinreb, a few years ago, he had from normal vision to blindness with glaucoma, so that we have to see where the patient is in terms of this evolution. And I think the same situation comes to keratoconus and ectasia, and eventually we can think about that for any disease in medicine, for most of them at least. So we have a very nice separation for the clinical cases, but we have to decrease the threshold. And cases like this one, she came as a candidate for laser vision correction. She was 2015 in this eye. You see topography from Placido and topometric maps from the Scheimpflug, very similar. This patient had a D of 1.35, which is kind of in the borderline, but the TBI makes it much easier to identify the susceptibility. And I can even say that the TBI version 2 goes up even a little higher here in this case. And the fellow eye of this patient is a patient that had mild keratoconus, unquestionable keratoconus in the left eye. So this very high susceptibility was detected in the eye still with a normal topography. However, ectasia susceptibility is the best term. We believe that unilateral ectasia, not monocular keratoconus, and as many people, and even myself, sometimes I take that I just say this is unilateral. Unilateral is not correct for keratoconus, because keratoconus is a bilateral disease by definition, but unilateral ectasia can occur. And this patient had a very nice result with a corneal ring in the right eye. He moved to London, and I had him seen by Professor Renstein in the London Vision Clinic, who has a prolific, actually, Rohit Shetty is the only one in the planet that has even more complete diagnostic information than Dan. And this is truly, truly amazing to see that the epithelial thickness was very normal. The Myung-Gatinel and Lansad score on the orb scan also came to be normal. So we published that in the International Journal of Keratoconus a few years ago. This patient had a normal TBI. This is the TBI from the first presentation that we could retrospective calculate. And in a later comeback of this patient at my clinic, he was still stable in this eye. So this is unilateral keratoconus. And from the global consensus, I come with a very nice, and I really like the Star Wars, the analogy that keratoconus is a bilateral disease. True unilateral keratoconus does not exist. However, any cornea may develop ectasia, and secondary ectasia can be unilateral due to the mechanical process. I used to think it would be one thing or the other, or the patient has unilateral ectasia, or the patient has form fruus keratoconus. But today, I evolved to the concept that this is like a continuum. It's and we will learn from technologies that can improve the understanding of the like the polarization of the OCT data. It can give you more hints on how the structure of the cornea is going, new biomechanical understanding, and eventually it will go to the genetics and epigenetics. And probably the group from Bangalore, led by Rohit Shetty, will be the top of the list to provide this data for us to elucidate this kind of a conundrum. One of the best cases that I have is this one. This is a twin sister, identical twin sister. This is the topography from Placido, and this topometric from Scheimpflug. And you see both eyes of the second twin sister are completely normal on topography. The TBI comes to be abnormal in all the 4 eyes. So we have 4 eyes with the same genes, and this was kind of proven. Actually, the first time I sent the genes, the genetic material from the twin sisters, they kind of confirmed. So we have a genetic proof that they are twin sisters. And interestingly, they didn't come with more information at the first glance. But today they have an Avogene test. This is the Avelino company, and they have some identification of susceptible genes for inflammation, and some of the information here can open the door for understanding that this patient had a genetic predisposition or susceptibility that would correlate with the TBI. So the next study that I would really be willing to see is expanding this into a large population so we can see this trend happening or not. Of course, this is a case report. So the first twin sister, she says, I rubbed more my eye than my twin sister, and she rubbed more the right eye than the left eye. So we have the impact from the environment. A very nice case series from Suzuka a few years ago in the ESCRS. She got the Corvis award on our session, and she had 3 little girls that were the daughter from a patient that had keratoconus. And you see the distance correct vision of all the 3 ladies, the 3 daughters were good, were better than 20/20. And the TBI was interestingly seen. So we need to see those patients in the future and follow up, and eventually telling them not to rub the eye will be probably a very, very important factor for them to not to progress with ectasia. So this is an unstable, unoperated eye from a patient that had LASIK ectasia in the left eye. So she's still stable, 2015. Borderline, we published that in 2010, and borderline, but it will be easily recognized as abnormal TBI in the unoperated eye. So this is ectasia susceptibility. It's hard to say that she has keratoconus in this eye with 2015, but I would say she is susceptible. And eventually we need to look at the genetic profile and other factors to expand this. This is the case Riccardo Vinciguerra, who is, by the way, getting married today. That's why he's not here. So Riccardo, congratulations. I wish you all the best. So this is the case that he pointed out at his great talk. And the patient had high myopia. And even though we had some borderline here in the BAD-D and low Artmax, in 2014, we were really excited about the biomechanical advantage of SMILE, and we decided to go for SMILE. She had a very nice result. 6 days after surgery, she was 20/20 plus in both eyes, very, very happy. She comes back 1 year, she comes back in 2 years. In 2 years, she was 20/25 plus 2 with this kind of abnormality. The other eye is still doing really well, but I would be able to detect this abnormality in the 2 years. She comes back 4 years after surgery, and the patient had a clinical ectasia. Interestingly, ectasia was very nicely detected in the right eye, but the left eye, as Riccardo pointed out, the biomechanics is still normal, but also I am very comfortable to say that she does not have ectasia based on epithelial thickness. Epithelial thickness was not with the pattern of ectasia, this donut thinning spot that Reinstein described as a first tomographic evidence of ectasia. In most cases, we can see that, but this epithelial hyperplasia is really making the point that the cornea is not bulging forward. I told the patient not to rub the eye when we treated her with a femtosecond intercorneal ring segments with the same laser that we did the SMILE procedure, the Dizomax, along with the cross-linking. She did really well, and we learn a lot from this case, especially not only how to treat post-myoctasia, but I really learned from the pre-op. She is stable in the left eye still, but in the pre-op, we come to frown to back and smile again. But the pre-op, we were able to back calculate. In 2014, we had the data, but we created the algorithm in late 2016. We published the paper in 2017, but we were able to use the raw data to back calculate, and she would be seen as a abnormal tomography and biomechanical index in the right eye. So it's something that we could learn. And as Rohit Shetty just pointed out, what about specificity? This is a patient that came as a candidate for laser vision correction with the diagnosis of keratoconus. Some other clinic would say you cannot do surgery because you have keratoconus. And of course, she has inferior stiffening. This is the classic Smollett-Kleist scale with 1.5. This is the classic Atlas scale, which is very popular in the United States. This is the topography Atlas from Humphrey's Eyes scale that is adapted on the Pentacam. Actually, one of the features I really like on the tomography and topography is to look at scales. That's the first thing you should look at. But if you change the scale, you can change the colors, and eventually you can change even your classification. But this patient had a mild myopia and a normal tomography in both eyes. And in that time, we decided to do LASIK. And I did LASIK in her, a topo-guided blended vision correction with the Alcon platform, and is using a topo-guided with an adjustment on the Q factor, on the asphericity. And she did really well. And she is coming back now about 5 years after surgery, really happy. And I see topography is stable, tomography is stable, everything else. And I said, well, let's take a look at her pre-op. And the pre-op on the retrospect, because when I did her surgery, I didn't have this data, but I retrospectively were able to calculate the TBI, and it was on the green side. So it's a very interesting situation on the retrospective evaluation of sensitivity and specificity in the case that was stable despite of the abnormal topography, and the case that had smile ectasia. And we're kind of collecting cases, and I invite everyone who is listening to this talk that is willing to collaborate with us is to share the U12 files if you have a Pentacam, and especially if you have a Pentacam and Corvus data. Let's take a look at this one, 20 years old, this very interesting case, 20 years old, -4, 2020, and this patient in the pre-op would be really, really abnormal. And this patient was one of the cases from my colleague and friend, Sri Ganesh and Shetal Brar, that collaborated with us, along with a group from many colleagues from India that I collaborate with, like Prema from Chennai, and many other great work that they are doing. This is how we learn. And this patient had ectasia after SMILE, even for mild correction. We are aware of cases that the TBI is not very good, and that's on the ROC curves. And some of the groups, they published sensitivities that were lower than what we published in the first report. Actually, we had a first validation from Iran, and then we had a validation from Dr. Pramadan from Chennai, and also from Rio, we got the external validations. But some cases are challenging. And Neil deGrasse Tyson has a very nice wisdom that knowing enough to think you're right, but not enough to know you're wrong. And I think about that all the time, especially when we try to evolve with some new technologies and some new things that we believe that they are really breakthrough. But we, understanding this is a revolution in evolution, we did an optimized TBI. This is a multi-center study that enhanced from less than 100 to over 550 very asymmetric normal topography cases. And these cases were really in agreement with the Belli and Ambrósio DV3, which is the one we have on the Pentacam for the sensitivity. It goes really down, even with a cutoff value of 1.27, but with the optimized work that was done by the colleagues on the brain, especially Dr. Deleuze Leão, who did a great work, very laborious work to data mining and find the features and use many algorithms. And the random forest 4, which is the one that is coming in the second version of the TBI, we enhanced the sensitivity from 75.7 to 84.4. We also get some cases down up here, and one of the works that I really want to do is to use finite element models like the work from Rohit Shetty for testing if this is a true, this case up here in the normal, in the green very high here, will be a true susceptible, and those cases down here are truly normal, stable corneas from unilateral ectasia cases. And of course, we are keeping the same sensitivity even with the highest cutoff value for the clinical keratoconus and clinical ectasia cases. So we have to understand what we're trying to achieve. And when we do refractive surgery, we are not trying to detect keratoconus only. Of course, we have to detect keratoconus, but we have to detect ectasia susceptibility. The concept of A square I squared is interesting, is artificial intelligence and philosophy, ancient intelligence applied. So we apply artificial intelligence with good philosophy, and this is explosive. And I do believe we are in a very exciting area for this planet, for evolution in many areas, and this concept can be applied for those, for many things. So enhanced optimized AI is a continuous evolution, but we still have to be doctors, patient education, and managing expectations are fundamental for us to do our work. And it goes in agreement with the primo non nocere from Hippocrates, do no harm first, and also to comfort always the patient, which is very, very important for us on the enhanced screening. So as Rohit Shetty just pointed out, we have an index that can help us what to do. If surface ablation, femtolasic, SMILE, or even phakic IOL. In some cases, they would need cross-linking. And understanding what the patient needs with the customized, personalized medicine will go from corneal imaging, whole eye wavefront imaging, and etc., to the molecular biology and genetics domain. And this is something really exciting that we are getting more and more of this information to help our patients with unprecedented ways. So this was a very, very special week for me because we started the campaign, the Vale June campaign, a few years ago in Rio, and I really had a dream. I actually literally dreamed to have the Christ, which I can see from my house, and to be violet as part of our campaign. And this week we went up there. This is my wife and me, and we had this coming true. Thankful for many colleagues and friends that connected us to the great people that take good care of this beautiful and marvelous monument for humanity. So this is Happy Violet June for all of you, and we look forward to more discussion. Thank you.
Thank you, Dr. Renato. Any questions from the audience, or anybody has to ask anything? And so we have covered more or less everything which we need to share. So if there's anything else, anybody has any questions, they can ask.
I have a question for you. Actually, I have a question for you.
Yeah,
when in your practice, I know you have a very, very sophisticated research environment, but in your practice, how do you use and how do you think people around the world will be able to use molecular biology and genetics for ectasia screening, ectasia treatment? How you see that coming in the future?
If I start dividing your question into two things, we'll look at first the genetic ones. And I think you must have seen that Avellino has already introduced a genetic kit for keratoconus. But what we need now is not just a geographic-centric kit. It has to be something which looks at the entire population, at least the population across the world. So what we are working on is trying to see if we can include the most common genes, which is seen in most of the world, Asian, European, Caucasians. So that is one big change which is going to happen. The second thing is molecular pathways. We see on the tiers that which we have been speaking about it has reached the stage where we're actually have a kit in the hospital now, in the clinics. And we have tied up recently with the Biogen, a company in US, which makes these kind of kits. So eventually it will roll out into a commercial one. And the panel has certain markers, but we can add more as we move on. And that's how this is going to be. I think plus or minus 2 or 3 years time, I think most of this will be part of, I mean, it could have been faster if not for COVID and other things, but I'm sure not only us, I'm speaking about many other groups. When 3 to 4 years from now, most of them, you'll have all these markers in your clinics along with the diagnostics we use.
Interesting. Sometimes I think possibly COVID can be an accelerated factor because we are talking about genetic identification of the virus as a simple thing. So the labs are now equipped for that. Labs that never did genetic identification of genes, amplification technology, this is more common. So they will have to use these technologies for some application, and these applications will definitely come on the top of the list, like the understanding dry eye and how you custom the optimization of the ocular surface before and after laser vision correction, cataract surgery, and this. So this is really an exciting time. Thank you for a great question.
Absolutely. So is there any other questions? If there's no questions, then I don't see anybody raising their hand. So if there's no questions, then we will end this session. I thank Dr. Renato, Dr. Vinciguerra, and all the participants who supported us in this meeting, and also the team from CAKE PIE EXPO for organizing this. Thank you, and hope to see you soon in a physical and live meeting so we can share more ideas and more thoughts on whatever has been discussed today. Thank you.
Thank you. That's how we evolve. Good to see you. All the best.
Thank you.